major study on survival by gestational age and weight, it was across Europe. And this was every birth across Europe. So this, once you start getting numbers over 100,000, you don't get very many of those studies. They don't come out all the time, right? But it really, this is meaningful, large-scale data. This is weeks of gestation. This is weight. These lines here, this is what norms are for weight at that gestation. Between the 10th percentile and the 90th percentile for weight. That's what this means. So if we were to look at weeks of gestation at 22 weeks, the percent survival is 2%. So when they talk about it's possible for the baby to survive, possible for some fetuses to survive, that's, I want you to understand the degree of optimism that is there. Okay. 23 weeks at 6%. 24 weeks, 16%. This is 1 out of 8 will survive. At 25 weeks, this is 33%, 1 in 3. All right? 26 weeks, we're starting over 50% now. At 26 weeks. 27 weeks, 72, 28 weeks, 84. You see how this picks up. By 32 weeks, 98% of fetuses are going to make it. And this is basically 2 months before your due date, right? 2 months before your due date. All right. Survival also varies by weight. The video is absolutely correct. Fat deposits make a difference in survival. Maintaining stable heat is important. If we look at survival, this is grams, between 250 and 500 grams, survival was about 3%. 22% between 500 and 750. I'm going to go to the next data later, but yeah.
When a baby is born at like 22, 23 weeks along, if they survive, do they have a lot of like developmental problems or?
Yes, they absolutely. That is very much. Yeah. And that's if we decide to resuscitate. If we decide to resuscitate. You know, and because there are various circumstances that could, you know, why is this person delivering at 22 weeks? One of my rare patients who delivered this gestation, it was because she had chorioamnionitis and came in with 105-degree temperature. So we've got an infection and 22 weeks. And we had a birth weight of under 500 grams. Right, and so you end up, you can have other complications besides what's on here too, right?
And then aside from the complications of being born so premature, the medical intervention that we have to do, like the trach and stuff, that can be long lasting.
Yeah, and we'll probably do
right?
We'll probably do an endotracheal tube,
Right.
Rather than a trach, but yeah.
Or that's what I mean, like for breathing too.
All of these things are difficult processes, yeah.
Are these are single pregnancies?
These were all by gestation and weight. My understanding is these were all of weight.
Does the gestation and the weeks and the survivability, does it change with twins significantly or at all?
Yes, it does change with twins. But this was for all European infants known to be alive at time of birth. These did not count stillbirths, but everybody else, right? I want to also point out one other thing. Do you notice that survivability drops off at the very upper limits of weight? Mm-hmm. That probably represents the weight of edema, like a baby who is profoundly anemic from certain conditions like hydrops, hydrops fetalis. We'll talk more about that when we talk about prenatal care. But do you notice, so for example, so this dotted line is the 90th percentile. So by the time you're getting weights all the way up at the top, right? That's representing a problem. That is representing a problem. Why should your weight be a third more than the 90th percentile? That's a lot. you're very much an outrunner at that point, right? And granted, this is all aggregate data, we don't, but just keep in mind that there's, very early on, weight is always a help. Weight is always a help in terms of survivability. But then as you start getting to 27 weeks, the extremes of higher weight do not help you when it comes. Now then, there is some updated US data. It is highly qualified. It looks a lot better than the older European data. But we should talk about that. The European data was all infants. This was selected infants. And they looked at gestation starting at 23 weeks. 23 weeks is usually the earliest we'll try in the US. And our survival rates, this looks a lot better, doesn't it, right? Up to 28.6, and you notice that they divided it from assigned male and assigned female. Overall, there's a little bit of variation here. Overall, there's a slight, survival slightly favors preemies who are assigned female, very slightly, if you look from measure to measure. And at 24 weeks, we're getting 48 to 55% babies to survive. Okay, and so you can see, but you can see there's still a big difference. We're not getting up to 95 to 98% till about 30 weeks, right? Till about 30 weeks. And you might notice that this was a much smaller study. These were small numbers. There were only 4 males and 8. No, this was a much smaller study. Let me tell you a little bit more about it. This is the last major study on survival, by the way, for preemies, and that was published in 2015. This was the latest data based on tertiary care centers in California. Our friends in California again. CMQCC data. It only considered data for those situations where the resuscitation was attempted or performed. So this was not all infants. This was only the ones they tried. Yeah, so do you see why I shared the older data as well as this data? Because this is heavily skewed. Okay, this is heavily skewed. Only 21% of the infants at 22 weeks gestation were resuscitated, and only 64% of the 23 weeks. This data was based on only on centers with a neonatal ICU. Okay. And if you're living in an outlying community and you have a smaller hospital, do you have the same resources? No. Will at very early gestations, will that baby need an ICU to survive?
Yes.
Yes. So they would have to be airlifted or transported. Do you have to be stable enough for this transport?
Yes.
Yes. So we would expect lower rates in outlying areas. By the way, will we transport those patients if they're in labor, if we can, in outlying hospitals? Will we try to transport them prior to delivery to a center within NICU? Yes, we will. But I want you to understand what the limits of our data are, okay, in those circumstances. All right, and lung development, we tend to think of the lungs, by the way, as being the last to develop. Because respiration, as I'm sure you know, that's a big deal, right? Our ABCs, right? Certainly we have an airway in a 23, 24 weeker, but do we have alveoli, a thin enough surface for gas exchange within the lungs, right? So we, starting at around 19 to 20 weeks, we have alveolar ducts, but you don't really have alveolar sacs till later, right? You're not really getting enough alveolar sacs till later. This is 36 to 38 weeks, okay? These weeks right here are generations of cells, So we're not really seeing great lung development, right? We're not really seeing great lung development where you can be born with a cry till you're about 36 weeks. Due dates are not written in stone. Most of them are plus or minus a week or two. Okay? So Do you see surfactant? We might start seeing surfactant at about 24.5 weeks, 25 weeks, but we don't have enough surfactant to keep the alveolar ducts or sacs open till you are about 34 to 36 weeks gestation. So this is around the area of time. Yeah, we don't really consider ourselves as having mature lungs, mature enough to breathe and survive till about 36 weeks. Okay? Both because the amount of surfactant and the development of the alveoli. Okay? So obviously respiratory support is important, isn't it? Yeah. And this website gives you just a little bit more, I think these graphics are a little better, but the other one was the surfactant that I wanted to show you, okay? And so that's, I also want to show you another thing. I mentioned weight is important. So our friends in Canada have been monitoring weight by gestational age for a long time. And so I wanted to show you just even a few things. Just a few years ago, there was a research trial that looked at the optimum timing of elective birth, especially as it related to repeat cesarean sections. When a patient has a repeat cesarean section, we're trying to avoid labor. You know, because we don't want them in labor, especially if they're worried about uterine rupture or things like that, right? But we want the baby to be mature enough that they don't need neonatal ICU. So there was a randomized controlled trial where they randomized people to deliver at 38 weeks versus 39 weeks. Nobody wanted to wait to the due date at 40 weeks because some of those patients would go into labor, right? Certainly some people go into labor on their own at 39 weeks too, right? So, but what's most desirable? And looking at the outcomes with the babies, there was a statistically significant difference between the number of neonatal ICU admissions between 38 and 39 weeks. And it was determined that 39 weeks is the optimum time for elective delivery in terms of fetal lung maturity in situations where we don't want to wait till 40 weeks. Okay, so 39 weeks over 38. Okay. So in other words, every week counts, doesn't it? Every week counts, right? It's not just a matter of having alveoli and surfactant, right? You have to have enough muscular strength to do that breathing. You have to be able to feed and have the strength to feed long enough to meet your blood glucose needs, right? Okay? You have to be able to maintain your body temperature because that costs calories too, right? That impacts your ability to feed and sustain yourself, right? So look at, and by the way, babies are also hepatically immature. And bilirubin levels, your risk of jaundice, if you're premature, is quite high, right? So when babies are born early, even a month early, they are, even when they have high survival, they can have higher morbidity because they are just so young. So if I were to look at, this is the bright blue line is the 50th percentile. I look at the 50th percentile at, we'll say 36 weeks, right? Right, that last month. And we're talking around 3850, give or take. Right, 2850 in terms of grams of birth, right? 2850. At 40 weeks, the 50th percentile is comparatively all the way up here. It's over 3,500. That baby has increased their weight by over a quarter in that last month. That brown fat babies are born with matters, right? So 50th percentile, 36 weeks. I'm at 2845 to be precise. And at 40 weeks, I'm at 3613. That's a lot of weight to gain. We like to be a baby's gain about a half a pound a week. Right? There are, between assigned males and females, there is a little bit of a statistical variation in terms of weight. And so that's 2744 at the 50th percentile for for assigned females, and at 40 weeks, that's 3470, okay? Again, roughly speaking, about this one's about 700 gram difference in terms of weight. But weight means is survivability, sorry, everybody have a 10% of that, so that is the 10%. Alright. And so, and these are the average weights overall. But this shows you the trend in terms of the growth curve of weight. Do you see this is almost a linear line here? Right? It starts to plateau once you get around 38 weeks. It starts to plateau a bit. Okay? The curve starts to slow. Okay? So this gives you a little bit better idea about fetal development. So prematurity is one consideration with implications for fetal development nursing care, right? We've got to provide respiratory support. We might need to treat bilirubin. We might need to feed these babies, right? We're going to keep them warm. Those are the basics. Okay? So prematurity is one consideration. There are other conditions. Some are preventable, some of them are less so. So I want to get into talking a little bit just about, very briefly, super briefly about genetics. Please do use your question cards, and we're going to talk about genetic testing more when we get into prenatal care. I think you probably all know that a genotype is what's in our genes, what's coded in our DNA. A phenotype is the adorable child, is what you get as a result of that DNA, right? It's what we show. A karyotype is a picture of chromosomes. This one has been nicely colorized. I want to point out, we know which chromosome is which by its size, right? They start out big and they're organized by size effectively, except with the exception of what we call the sex chromosomes. Okay? Okay. Normally we have 23 pairs of chromosomes, including one pair of sex chromosomes, typically XX or XY. Aneuploidy, major chromosomal disorders, which we refer to as aneuploidy, right? An abnormality in the chromosome count. It usually comes from non-disjunction, from the chromosomes not separating. Monosomy, the most common monosomy that most of us know about, which means you have only one chromosome instead of two, would be Turner syndrome, which is XO configuration. Trisomies or triploidies is another term for that. Trisomy 18, 21. This was referred to as triple X. Klinefelter syndrome, XXY. You can see a karyotype here of a assigned female child who is trisomy 21. So this is a karyotype of an actual person. Okay? And this represents non-disjunction during meiosis, right? Everybody remembers meiosis once back way back. Structural chromosomal anomalies tend to be new mutations. Okay, they tend to be new mutations. There can be translocations, where they flip or change places. Duplications, inversions, inversions are where they flip. Ring formation, sometimes chromosomes will break off and make a ring. Mosaicism refers to having some cells that have a normal chromosome count and some that do not. So let's say we start out with a normal zygote with a normal chromosome count. It starts to divide, and then at one of the divisions, there was non-disjunction. Then you can have an abnormality in the chromosome count for some of the cells of that person, but not all of them. And the term mosaic, like tile, there are different types of tiles. There are different types of cells. Some of them have mutations, some of them don't. We refer to this as somatic mutations if they occur in the regular tissues of the body. If it occurs in the ovaries or testes, it's a germ cell mutation. It could affect future generations. Somatic mutations will not, though. If the chromosome count in my arm is abnormal, it's not gonna hurt the rest of me. And it won't be, I won't pass it on to my kids. Does that make sense? When I talk about somatic mutation. Soma means body, right? Body, somatic. And then there are major structural anomalies, some very serious anomalies like breaking chromosomes, translocations, duplications, inversions. They tend to be new mutations because they're not necessarily compatible with reproduction. They tend not to be passed on because they can lead to infertility and problems getting pregnant later. Deletions can also occur. When the short arm of chromosome 5 is deleted, it can lead to Cri-du-Chat syndrome. Cri-du-Chat is French for cry of the cat. And the children who have Cri-du-Chat have a particular formation of their larynx that makes them sound like a cat. And another helpful thing to know for those people for labor and delivery is that when there is a problem in pregnancy, like premature labor, it's been found that 2/3 of pregnancies affected by trisomy 21, they abort or have preterm labor, 2/3. When there is a serious chromosomal anomaly, there are more likely to be problems during the pregnancy. It's associated with labor and delivery complications. And it's not so much complications giving birth, it's complications with the pregnancy. I did have a patient once who had a baby with Cri-du-Chat. In her pregnancy, she came to us, they say transfer of care, and she came to us with an ultrasound report, and her uterus wasn't measuring what it should. The patient was transferred to me, I was the midwife at the hospital, and I put my hands on to examine her and found she had no amniotic fluid. I could tell by feeling it was so little amniotic fluid. And we got a consultation, her baby's heart tone started to crash, and we did a cesarean section at 33 weeks, and the baby had Cri-du-Chat. We diagnosed it when the baby was extubated, because the baby needed intubation, so the baby needed some ventilatory support. And the neonatologist one day is like, "Where's the cat? We're on the 3rd floor, how do we get a cat up there?" Because the baby truly sounded. So be aware that serious pregnancy complications can occur when there is a chromosomal anomaly. That is an association, and a strong association, okay? For when a gene, thinking about other genetics, right? If the gene for a characteristic is found on pairs 1 through 22, we call it autosomal. If it's on the X chromosome, we call it X-linked, such as X-linked hemophilia A. Y-linked disorders, just in case someone's curious, are relatively rare. They do occur. Fruit flies, the ones who have white eyes, that's a Y characteristic. There's certain types of rare infertility that can also occur. They're associated with their Y-linked. Okay. You probably all know by now, a gene is a segment of DNA that codes for the manufacture of a protein. Proteins can be both structural and enzymatic, right? Mendelian inheritance, genetic disorders can be related to single genes with recessive or dominant traits. Some selected conditions that are recessive. With recessive, the patient must have, the baby must have 2 genes, right? One from each parent in order to demonstrate the phenotype. Some specific examples include cystic fibrosis, Tay-Sachs disease, spinal muscular atrophy, which is abbreviated SMA, phenylketonuria, PKU. There are many other conditions of normal variations, unattached earlobes, thin lips. Those are recessive characteristics. Okay? And I just want you to know that these 4 things are recessive. That's what so when I list, sometimes when I've listed, I want the nurse to be aware of these things in your study guides. That's what I want you to know, that these are recessive. That's it. Okay? when you have autosomal recessives, you have, and you have two parents who are carriers, then odds are 1/4 would be unaffected, 1/2 are carriers, and 1/4 is affected. It's independent. It's what we call the law of independent assortment. Each pregnancy is a 25% chance of an affected child. Each pregnancy, right? So if you have one child who has cystic fibrosis, then the next child has what chance? 25% again, yeah. Mm-hmm. Yep. Law of independent assortment, right? Depending on, we talk about recessives as skipping generations, right? Everybody hear that phrase? I know I heard that phrase growing up, right? Skipping generations, right? And so some of our patients think that these conditions literally skip like every other generation. People literally think that. Is that true? No, that's not true. For cystic fibrosis in particular, we know that most of the people who have a baby with cystic fibrosis had no idea that they had the gene. They'd never had another baby in the family with that condition, so they didn't know that it was in their family. So a lot of times people have recessives that they don't know about. Anybody ever know somebody who like did 23andMe or something and found surprises?
Mm-hmm.
Yeah, just here for it. All right, in the case of a dominant trait, the individual only needs one gene in order to demonstrate the phenotype. Huntington's disease is one example, so are dimples, curly hair, polydactyly, all right? And with autosomal dominant disorders, because they are dominant, you do tend to see them in every generation, okay? And if you have one parent who is affected, who has a gene, and the other one is unaffected, then each pregnancy has a 50% chance. Each pregnancy has a 50% chance. With X-linked traits, these are recessives. By their very nature, they're recessive. And so if an assigned female is a carrier, assigned males only have one X chromosome, so they will have that trait. They don't have the opportunity of a dominant gene to come along, right? But if the baby is an assigned female, then they have a 50-50 chance of being a carrier. They would get their father's X chromosome, in this case, if the father doesn't have them. They would get their father's X chromosome, and they would either get the affected or unaffected chromosome from their mother. Because it's recessive, they won't have the trait. Now then, can females have X-linked conditions?
Yes.
Yes, they'd have to have both genes though. So-called male pattern baldness is one of those conditions. Okay. True story, my mother was virtually bald by the age of 32. Who do I have to thank for my hair? Dad, who had hair all his whole life. What are the chances that my brothers will go bald?
Pretty good.
Sorry, bros, all of them, right? Because my mother only has two recessives because she is bald, right? She only has a recessive to give them. What are the chances that my son will go bald?
Pretty good.
Pretty good. What numerically? 50-50, right? I have to have the recessive because it's the only gene my mother has to give me. I have the dominant one from my, my father had hair, so I have the dominant one from right. So my son has a 50-50 chance. He's 27 now, we'll see.
But what about your son's child will pass?
We don't know what he is yet. We don't know what he is yet, though. We don't know if he, yeah.
Yeah.
Right. All right. When in doubt, draw a Punnett square. Remember Punnett squares like from high school and stuff, and Mendeleev's and all that? Cool. All right. Non-Mendelian inheritance is good to know about too. Not everything follows Mendel's rules, right? All right, we can have codominant traits like AB blood type. If you have a gene for type A and a gene for type B, you have the phenotype for both, right? You have AB blood type. You have both. There is such a thing as incomplete dominance, as can occur with sickle hemoglobin. The heterozygote is AS hemoglobin, and there is some small degree of impact from having one gene that is sickle and one gene that is not. Okay? So incomplete dominance. You can have penetrance as an issue. Penetrance means that the gene has to have a specific environment to be expressed. The cancer suppressor genes, BRCA1 and 2, penetrance is a thing, right? They have someone who has BRCA1 has a 60% chance of developing ovarian cancer if they have ovaries, right? It is considered a dominant gene, by the way. But only 60%, that's not everybody, is it? No, it's still high rate, isn't it? It's an awfully high rate of ovarian cancer. Yes. However, and that's because the gene has to have a specific environment in order to be expressed, right? All right, so I have dimples. That was another thing I got from my dad. And so when my kids were born, I was kind of hoping they'd get dimples too. And you always hope that something, And so when they were born, they didn't have dimples. And I thought, oh, they're adorable. One of them got their dimples when they were 9. And the other one didn't get them till they were 13. They both have dimples though. I was born with mine. There are pictures of me as an infant with dimples. That's penetrance. It had to have a specific environment in order to be seen phenotypically. Dimples are dominant, by the way. So that was penetrance. An environment had to be in place in order for the gene to be expressed. There are polygenic conditions, multiple genes involved, like eye color, height, or things like that. Prevention. So how do we prevent genetic disorders, right? When the family has a known risk. Yeah. Ends up there's all kinds of options. I made you a list. All right? People could decide to become parents by adoption if they want to have a family and they know they have a risk of an inheritable condition. A serious inheritable condition, right? They could decide not to become a parent and be child-free, right? They could, and people can have children in their lives in a variety of ways. Some people volunteer in elementary schools or all kinds of ways. And some people decide not to, right? They could decide to use donor semen and or ova, right? They could use donor semen. They could decide to adopt embryos which have been screened, right? They could do embryo adoption and IVF, right? They could decide to use in vitro fertilization with pre-implantation genetic diagnosis and elect to implant only the unaffected embryos. This adds about an additional $2,500 to the cost of IVF. $2,500, $2,500. I understand that most people are electing to do that these days, actually. That most people are deciding to do that, who are doing IVF, right? Right? Yeah. By the way, the cost of IVF is usually somewhere around $12,500 to $15,000 per cycle, and then this adds another $2,500 on top of that. So we're talking around, $15,000 to $18,000 ballpark in there. People who do IVF, it's not usually covered by insurance. I understand Microsoft covers part of the cost if you have Microsoft type insurance, but that's the type of insurance it takes for this. So you can imagine this is not an option for most people. Do people have a right to know about choices though? Yeah, they do. They have a right to know. You never know. Maybe they have a rich uncle or somebody who can help them more. There are some people who have a house and will mortgage their house. The infertility clinics often have finance programs to finance, and sometimes they will make deals like, all right, pay us $40,000 and we'll keep trying this till you get a baby. Yeah, things like that. There's, yeah, exactly, yeah. Because I mean, how many, it's true, how many times, for people who don't achieve a pregnancy after a few times, how many times do you want your heart to be broken, right? And, yeah, it can be hard, right? But certainly IVF, does exist, right? And it is an option. People do have IVF and are successful, sometimes with IVF from other strategies that work. One of my friends has IVF twins, and, yeah, all right. They could use to decide sperm sorting if the concern is an X-linked condition like hemophilia, like an X-linked hemophilia. So sperm sorting might be, that has a range of success. I think we're better able to get a specimen that is mostly X than we are mostly Y, sorting them out by weight, effectively by weight. Yeah. There's a machine that does this, it's called microsort, anyway. You could decide to have a spontaneous pregnancy, right? And to have diagnostic testing or screening during pregnancy, okay? Patients could decide to have a spontaneous pregnancy and parent the baby they have, again, right? People have choices, right? Life is not a risk-free adventure. And sometimes people are like, I'm gonna have my baby and love my baby, whatever happens, happens, right? One of my friends, her husband had Huntington's disease and passed away from Huntington's disease. And they decided to have children. One child did have Huntington's disease, and one child did not, right? And so they decided to live life the way it happened. And people have very different philosophies, right? But it's important that we offer people who are aware and know about some options here. Certainly people can be tested while they're waiting prenatally, right, or preconception, right? So what about non-genetic causes, lifestyle and maternal conditions? When's the best time to prevent birth defects? First thing, and even before pregnancy happens. Yeah, before pregnancy happens, right away, right? And so teratogens, we can limit teratogen exposure. We already kind of briefly mentioned that. Teratogens are the things that are harmful in pregnancy. The impact of any given teratogen depends on the timing of the exposure, the gestation at which it occurred, right? So you just saw all that fetal development, right? So when is the greatest harm?
First trimester.
First trimester, specifically those first 10 weeks from the last menstrual period are the biggest ones, right? We can also have chronic exposure, like every day. We could have intermittent exposure, like binges and things. Okay? The type of teratogen matters too. It could be a virus, like rubella, that can cause deafness, right? It could be like, or varicella, okay? Those are viruses that can be harmful in pregnancy. It could be a metal like lead or mercury. Lead and mercury are harmful in pregnancy. It could be a medication, like things that interfere with folate metabolism, increase the risk of neural tube defects. No Accutane or retin A when people are pregnant, because they interfere with folate, right? There are some medications that are harmful in pregnancy. So retin A and Accutane are given the list. Certain chemicals can be harmful in pregnancy. We need to know what the patient's exposed to. There can be environmental exposures to things that are harmful or dangerous. Potency, how potent is the teratogen? Some are more serious than others. The amount they received dosage. This is probably the most popular teratogen. This is ethyl alcohol. And generally speaking, if somebody gets a pregnancy test right away when they miss a period, and remember, it takes a while to get implantation. If they test right away, find out that they're pregnant and don't have any more alcohol, they're usually going to be okay. Can I make promises that I can't keep? No. I'm so glad you found out you're pregnant. I'm so glad that, people feel guilty. It's like, oops, I had a drink last weekend. Just don't do anymore, okay? A lot of the brain growth actually happens after 20 weeks. We just want those early cells and the early structures to develop normally, right? Fetal alcohol syndrome. is, and we should be looking for these characteristics, by the way, when we do our newborn assessments, is characterized by widely spaced eyes, a narrow eye opening, the eyelid itself will open, will be narrow. A flatter midface, a smooth philtrum. Philtrum is the upper lip here. So this is a baby with FAS. Okay, instead of being grooved, smaller head circumference, smaller than expected head circumference, cognitive impairment and developmental delay to various degrees. We call this a spectrum disorder because it depends on how much and when, right? Most of the facial impact is going to be quite early, like around day 42, right around in there. So it's usually fairly early that the facial effects happen.
Does the philtrum, does it ever, like, you ever get that indentation at some point? Or is it always?
It's usually, it's always, that's,
Huh.
yeah. And there is genetic variation too. I mean, if you see somebody with smooth philtrum and they seem to be okay, they're okay, right? I mean, you know, there is human variation, and sometimes, you know, certainly we're gonna look for all these things, but let's just say they had a smooth philtrum and a normal head circumference, and everything else is checking okay with the baby, and you look at the parents and you see the same thing in the parents, it's like, well, maybe it's genetic for them, right? Maybe that's, because it's not like these are not pathognomonic symptoms. None of these individual symptoms are pathognomonic where if they have this, they must have this, right? This is a constellation of potential symptoms, right? You can have microcephaly, a smaller head circumference, for example, from Zika. Remember Zika? You can also have it from CMV. These are viruses that are teratogenic. Zika and CMV, varicella, rubella, COVID is on our list. It doesn't cause structural problems. It causes other issues. Placental perfusion and placental structural problems is what it seems to cause. Preterm labor it causes, things like that. So there's, so you get a smaller head circumference with a variety of different things, right? But when you start to see things to come together, then you wonder about, could this be, right? And then that's a consult with a pediatric provider to have them assess, right? And express your concern and to have a further evaluation. And the provider will evaluate the baby too, have a talk with the parents, and yeah. Okay, so that's something to be aware of. All right, our latest concern is marijuana. Pot users, first off, trying to get pregnant, it can decrease fertility. It increases the risk of miscarriage, anencephaly, preterm birth, low birth weight, SGA, small for gestational age, or intrauterine growth restriction. It does not impact birth weight, though, quite as bad as tobacco. Tobacco is about twice as bad on birth weight for babies. Stillbirth, anemia. We don't have great data, by the way. We don't have great data on a lot of teratogens. Most of the studies are done on observations. Because I can't say, okay, you guys, you know, just like I said before, you guys only have one joint a day. You guys, I want you to have some brownies that have, you know, you guys, I want to try you guys with the CBD oil and see what that does. You know, I can't do that, right? Nor would I, you know, nor would I. But that's why we say these things, and we say we see these risks, right? We talk about it as risks because human beings don't work like light switches. It's not like you have one joint and the baby is going to be horrifically deformed or something, you know. But it's not like that. It is dose related. It's timing related. It's a much more nuanced equation. Having said that, do I want anybody to do anything? No, I don't. Do I, you know, we don't have great data. We do know that avoiding alcohol and pot is healthy, right? You can't have an effect on your baby if you don't have exposure to those things, right? Do we have an absolute on any of this? No, we don't. Do we know what safe levels could be, right? For example, in European cultures, it's very common to have wine with dinner and stuff. Do we know that, you know, do we know how much harm that is? No, we don't. We don't have great controlled research. What we know is that 0 is safe, and those are the recommendations at the merchant times, right? You know, am I horribly, I remember I had a patient who told me that once a week she had a glass of wine with her husband at dinner only on Friday nights, and it was just one. Did I caution her that I'd recommend none? Yes. Do I know of it being harmful? No. Right? Do I know that alcohol is dose related? Yes. Would I rather she not? Yes. But I don't have that, you know, it's like, you know, we really recommend that you not. Really? Yeah. Really? You know, we don't really have safe levels. People in Europe, I said, yeah, I know. We just haven't done the research to really know. We can't really do that research. We know that 0 is safe. Right? Marijuana exposure can lead to neonatal absence syndrome. It can impact neurologic development. People are worried about memory in particular. It is not a safe treatment for nausea. CBD products have been marketed sometimes for nausea. We do not consider it to be a safe product for nausea. Cannabinoids, by the way, CBD, even though it's not the psychoactive component, it can be converted to THC in your liver, by the way. And there are plenty of things that aren't psychoactive that are harmful in pregnancy. Tetracycline is not psychoactive, right? You don't have to be, Accutane isn't psychoactive. The lack of psychoactivity doesn't mean it's safe in pregnancy. All right, so preconception risk reduction, we're gonna assess occupational exposure of the patient. Are they exposed to teratogenic chemicals or metals, pesticides, or hazards? Remember those safety sheets, material safety data sheets, things like that? Yeah. Yeah, and yeah, we look at those, right? I will have patients bring them to me in the office if they have questions about what they're exposed to at work. Show me what you're exposed to. Lifestyle exposures, tobacco, marijuana, opioids, right? Alcohol, and things that are prescribed too, right? Cats, because they can carry toxoplasmosis, which, yeah, cat box parasite. Small children, they bring home all kinds of things. Diet, you know, ideally patients should be at a desirable body mass index between 19 and 25. We want to assess genetic risk, family history, prior medical history. I know I mean prior medical history too. I mean things like, well, I'll get this. Partner's history, right? Prior medical history. Here's where I want to talk about this. Things like chronic hypertension, right? You might have to perfuse a pregnancy, right? Hypertension matters. Diabetes should be in good control. Blood glucose levels that are in the 550 range are teratogenic. Patients who have diabetes that is not in good control have a higher risk of a baby with a heart anomaly. So having diabetes in good control is important in gestation. Sugar, blood glucose can be teratogenic in high enough amounts, right? And like I said, I'm talking really high, like in the 550 range, right? Asthmatics tend to have smaller babies. They should be in good control too. Thyroid disorders associated with miscarriage, that needs to be in good control, okay? Check vaccine records and current family planning methods of a patient's ability to get pregnant. And then let me just review these and then we'll have lunch. Our potential interventions are to counsel on the discontinuance of family planning. For hormones, we recommend at least 3 months in advance, okay? An exception was Depo-Provera, or example, I should say, Depo-Provera, we wait for a year and a half, right? I'm sorry, we can wait for infertilities after a year and a half with Depo. With Depo, it can take longer for their periods to return. We want to talk to them about when to try to get pregnant, to write down their periods so we can date the pregnancy well. We want to tell them to get a pregnancy test when they miss their period. We want to talk to them about prenatal care and to get prenatal care right away. And what we mean by that is when you have a positive pregnancy, call for an appointment. It's not an emergency appointment. Chances are it might be 2 weeks or even a month out. But the longer you wait to call to get an appointment, the longer it takes to get you in the office, right? When they should get help if they don't get pregnant. educational and lifestyle and risk factor avoidance. They should have dental care to get their teeth and mouth in good condition. Periodontal disease increases the risk of preterm birth. Yeah. They should take prenatal vitamins or folic acid supplement in order to help reduce the risk of neural tooth defects. You should refer them to services based on their risk factors such as dental care, preconception genetics, counseling and consultation. Routine recommendations include cystic fibrosis screening that should be available. Hemoglobinopathies can be assessed as well, and SMA, spinal muscular atrophy. We should administer and update them on their vaccines, and we can check databases or antibody titers with vaccines given if they're non-immune or not immunized. Risking COVID and flu vaccination is recommended. And we need to perform for additional assessments and referrals, blood draws for genetic testing, and management of concurrent medical conditions, particularly chronic hypertension, diabetes, thyroid disorders, and asthma.